Put the stethoscope on the belly. Upper right, nothing. Upper left, nothing. Lower right, lower left, nothing, in all 4 quadrants. The abdomen is firm and distended, and the last bowel movement was 4 days ago. The patient will tell you their stomach hurts. The monitor will tell you the vital signs are fine. The most important finding in this room is a sound you cannot hear. A gut that has gone silent is a gut that has stopped moving, and that is an emergency hiding in plain sight. By the end of this, you will listen to an abdomen, read a bleed, and tell a blocked gut from an inflamed one from a failing liver, and know what to do first. This is the GI system. All of it. Let's build it from the ground up. Chapter 1. One tube for problems. Strip away the names, and the entire digestive system is a single tube, open at both ends, with a different job at every level. The mouth and esophagus move food down. The stomach mixes it with acid. The small intestine absorbs the nutrients. The large intestine reclaims water and forms stool. And along the way, 3 organs pour in their help: the liver, the gallbladder, and the pancreas. One tube, one direction, many jobs. Here is the frame for the whole course. Every disease of this tube is one of exactly 4 things. Something is blocking the tube, an obstruction. Something is inflaming it, appendicitis, diverticulitis, inflammatory bowel disease. Something is bleeding into it. Or something is failing to process what is inside it, the liver, the pancreas, the gallbladder. Block, inflame, bleed, or fail to process. Sort any GI finding into one of those 4 buckets, and you already know what kind of problem you are looking at. One idea to carry through all of it: motility, the movement of the tube. When the gut moves normally, you hear active bowel sounds. When it moves too fast, you get diarrhea and hyperactive, high-pitched sounds. When it stops, from a blockage or from a paralyzed gut after surgery, the sounds disappear and the belly distends. So the stethoscope is not a formality. Absent bowel sounds with a distended, painful abdomen is the finding that changes the plan. Our patient is a man in his 60s with long-standing cirrhosis, a liver scarred by years of injury. He has been managing, until tonight, when he started vomiting blood. His liver is the failing to process bucket, and it is about to show us how one failing organ sets off a cascade that touches every other part of this tube. But before the liver, we start where his symptoms started, at the top of the tube. Chapter 2. The Upper Tract. At the top, 2 problems that both come down to acid in the wrong place. Reflux disease, when the valve at the bottom of the esophagus is weak, so stomach acid splashes up. The classic symptom is heartburn, worse lying down and after big meals, and over time that acid can damage the esophagus. Peptic ulcer disease is a step deeper, an actual erosion through the lining of the stomach or the first part of the small intestine, worn open by acid. The pain is burning and gnawing, and it has a tell. A stomach ulcer often hurts more with food. A duodenal ulcer often feels better with food, then worse a couple of hours later. And the cause behind most ulcers is not stress or spicy food. It is a bacterium, H. pylori, plus the NSAID pain relievers that strip the stomach's protective lining. So treatment is a combination. Antibiotics to kill the bacteria, and an acid reducer, a proton pump inhibitor ending in prazole, to let the lining heal. Teach them to finish the full antibiotic course, and to avoid the NSAIDs, alcohol, and smoking that keep the acid attacking. The dangerous complication is when an ulcer erodes into a blood vessel, and it bleeds. Our patient does not have an ulcer. His bleeding is coming from somewhere else entirely, from swollen veins in his esophagus, that his liver disease created. But whatever the source, blood in the GI tract behaves in predictable ways, and where it shows up tells you where it came from. That is Chapter 3. Chapter 3. Bleeding. Blood in the GI tract sorts into upper and lower, and the trick is that the blood changes color depending on how far it travels. An upper GI bleed, from the esophagus, stomach, or duodenum, gives you 2 signs. Vomiting blood, which may look bright red or like coffee grounds when the acid has worked on it. And melena, black, tarry, foul-smelling stool, because the blood has been digested on its long trip down. A lower GI bleed, from the colon or rectum, gives you bright red blood in the stool, because it has not traveled far. So, black and tarry, think upper. Bright red per rectum, think lower, or a very fast upper bleed. That one distinction points you at the source. Whatever the source, a GI bleed can become hemorrhagic shock. So the priorities are the priorities of any major bleed: airway and breathing, 2 large IV lines, fluids and blood products, and watch for the falling pressure and rising heart rate of shock. For an upper bleed, they will be kept nothing by mouth, and an endoscopy will find and stop the source. And for a patient's kind of bleed, bleeding esophageal varices, there are specific drugs to lower the pressure in those veins, and a scope to ban them. Pause. A patient reports several days of black, tarry stools and now feels dizzy and weak. Heart rate is 110, blood pressure 98/60. What is happening, and what is the priority? The black, tarry stool is melena, a sign of an upper GI bleed. And the rising heart rate with the softening pressure means enough blood has been lost to threaten perfusion. The priority is to treat it as a significant bleed, large bore IV access, fluids and blood as ordered, keep the patient nothing by mouth, and prepare for endoscopy. Melena is not a minor complaint. It is digested blood, and it means a bleed higher up. Our patient's varices are banded, the bleeding stops, and he is stabilized. A crisis survived. But the blood that spilled into his gut is about to cause a second, slower crisis. And to understand it, you have to understand his liver. We are getting there. First, the 2 other ways this tube fails: blockage and inflammation. Chapter 4, Obstruction. When the tube is blocked, everything upstream backs up, and everything downstream empties out. A mechanical obstruction is a physical blockage, adhesions from old surgery, a hernia, or a tumor. The gut above it distends and its sounds go high-pitched and tinkling as it strains against the block, then fall silent. A paralytic obstruction, an ileus, is different. Nothing is physically blocking it, but the gut has simply stopped moving, most often after abdominal surgery or from certain drugs. Either way, the picture is the same: a distended abdomen, no stool and no gas passing, vomiting, and the emergency version of that silent belly from the cold open. The care is about decompression and support. Keep them nothing by mouth so nothing new goes into the backed up tube. Insert a nasogastric tube to suction out what is trapped above the blockage, which relieves the pressure and the vomiting. Give IV fluids because they are losing volume into a gut that cannot reclaim it. And monitor, because a mechanical obstruction that is not relieved can cut off blood flow to that segment of bowel, and dead bowel is a surgical emergency. Our patient's tube is not blocked. His problem is upstream, at the organ that processes everything the tube absorbs. But the third bucket, inflammation, is the one that sends the most people to the emergency department clutching their bellies, and it hides a distinction between pain that can wait and pain that cannot. That is Chapter 5. Chapter 5, the Acute Abdomen. Appendicitis. The appendix, a small pouch off the large intestine, gets blocked, inflames, and swells. The pain starts vague, around the navel, then localizes to the lower right, to a spot called McBurney's point, with nausea, low fever, and a rise in white cells. And here is the trap you must know. If that pain suddenly disappears before surgery, do not relax, that is not improvement. It usually means the appendix has ruptured, releasing the pressure, and spilling infection into the abdomen. Sudden relief of appendicitis pain is an ominous sign, not a reassuring one. And what you do not do for a suspected appendix is as tested as what you do. Do not palpate the abdomen deeply, you can rupture it. Do not apply heat, it increases blood flow and can worsen it or speed a rupture. And do not give a laxative or an enema, which can also cause it to burst. Keep them nothing by mouth for surgery, position them for comfort, and manage pain. The instinct to soothe with heat or to clear things out with a laxative is exactly the wrong instinct here. And this is the emergency the whole abdomen can become. Peritonitis, inflammation of the lining of the abdominal cavity, when infection or contents spill into it, from a ruptured appendix, a perforated ulcer, a burst diverticulum. The abdomen becomes rigid, board-like, and exquisitely tender, with rebound tenderness, more pain when you release than when you press. The patient lies still with knees drawn up, because any movement hurts. A rigid, board-like abdomen with rebound tenderness is a surgical emergency. You escalate that, now. Our patient's abdomen is distended, but it is soft and it is full of fluid, not infection, at least not yet. That distinction, soft and fluid-filled versus rigid and board-like, is the difference between his chronic problem and a surgical crisis. But before we reach his liver, there is one inflammation that is not an emergency, but is the single most tested comparison in GI nursing. That is Chapter 6. Chapter 6. Crohn versus colitis. Inflammatory bowel disease is the immune system attacking the gut, chronically, and it comes in two forms that nearly every question hinges on distinguishing. Crohn's disease can strike anywhere from mouth to anus, but it skips, leaving healthy patches between inflamed ones, and it burrows through the full thickness of the wall, which is why it causes fistulas and strictures. Ulcerative colitis stays in the colon, starts at the rectum, and spreads upward in one continuous stretch, and it stays shallow, only the inner lining. So the pattern is the tell. Crohn's, anywhere, patchy, and deep. Colitis, colon only, continuous, and shallow. Crohn's classically causes crampy pain and non-bloody diarrhea. Colitis classically causes bloody diarrhea, many stools a day. Both are managed by calming the immune system, with anti-inflammatories, steroids in a flare, and immune-modifying drugs, plus rest for the bowel and attention to nutrition, because these patients lose weight and become deficient. And 2 long-term watches. Ulcerative colitis raises the risk of colon cancer, so they need regular colonoscopy screening. And Crohn's fistulas and strictures often eventually need surgery. Same category, 2 diseases, and the exam will always ask you which one you are looking at. Pause. A patient has patchy inflammation found from the small intestine to the colon, with healthy segments in between and a fistula. Which condition is this, and what one feature told you? This is Crohn's disease. The feature that told you is the pattern, patchy inflammation with healthy segments in between, the skip lesions, plus involvement beyond the colon and a fistula from full-thickness disease. Ulcerative colitis would be continuous, confined to the colon, and shallow, and it does not form fistulas. The distribution is the whole answer. Patchy and deep is Crohn's. Our patient does not have inflammatory bowel disease. We have now walked 3 of the 4 buckets, bleeding, blockage, and inflammation, and set his aside each time. Because his problem is the 4th bucket, and it is the one that ties this entire course together. The liver. That is Chapter 7, and it is the flagship of this whole video. Chapter 7, the Cirrhosis Cascade. Before the disease, the jobs. Because every symptom of liver failure is one of these jobs not getting done. The liver detoxifies the blood, including turning ammonia, a waste from protein, into something the kidneys can excrete. It makes the proteins that clot your blood and the albumin that keeps fluid inside your vessels. It processes bilirubin, the pigment from old red cells. And it stores and metabolizes, well, almost everything. Now scar the liver, cirrhosis, and it can do none of it well, and it becomes so stiff that blood cannot flow through it. And that stiffness starts the cascade, one connected story. Blood that cannot get through the scarred liver backs up, raising the pressure in the portal vein. That portal hypertension pushes blood into smaller vessels that were never meant to carry it. In the esophagus, they swell into varices, which rupture and bleed, our patient's first crisis. Fluid, driven by that pressure and by the low albumin the liver can no longer make, weeps into the abdomen as ascites, the pale straw fluid that distended his belly. The spleen enlarges, and the ammonia the liver can no longer clear rises in the blood, crosses into the brain, and causes hepatic encephalopathy, confusion, drowsiness, and a flapping tremor of the hands called asterixis. One scarred liver. Every one of those, connected. So the care maps onto the cascade. For the ascites, a low-sodium diet and diuretics, and sometimes draining it with a needle. For the bleeding risk, because the liver cannot make clotting factors, watch for any bleeding and avoid injury. Avoid every hepatotoxic drug, the acetaminophen, the alcohol, that would injure what is left. And for the encephalopathy, the key drug, lactulose. Lactulose traps the ammonia in the gut and pulls it out in the stool, and it is titrated to 2 or 3 soft stools a day, which leads to the trap. You do not hold lactulose because the patient is having stools. The stools are the drug working. You would only worry about too many. Pause. A cirrhosis patient on lactulose has had 3 soft stools this shift. A new nurse asks whether to hold the next dose because the patient is stooling. The patient is also more confused than yesterday. What is the correct action? Give the lactulose and reassess. 2 or 3 soft stools a day is the goal. It is the sign the drug is removing ammonia. Holding it would let the ammonia climb, and the increasing confusion tells you the encephalopathy is worsening, not resolving. The trap is treating the stools as a side effect to be stopped. They are the therapeutic endpoint. You would only question it if the stools became excessive. Our patient's confusion is exactly that. Ammonia, the scarred liver can no longer clear, made worse by the blood he bled into his own gut, which is pure protein for bacteria to turn into more ammonia. Lactulose brings it down, and over days his mind clears. His whole story, the bleed, the fluid, the confusion, was one liver failing. And the most common way a liver gets injured in the first place is a virus. That is Chapter 8. Chapter 8. Hepatitis. Hepatitis is inflammation of the liver, and while there are many causes, the viral ones are what you must be able to separate, because how they spread determines everything about prevention. And the way to keep them straight is transmission. Hepatitis A and E are fecal-oral, spread through contaminated food and water. They cause an acute illness, usually self-limited, and they do not become chronic. Hepatitis B, C, and D spread through blood and body fluids, needles, sex, and from mother to baby. And these are the dangerous ones, because they can become chronic, and chronic B and C are the leading causes of the very cirrhosis we just spent a chapter on. So the teaching follows the transmission. For A and E, the fecal-oral ones, it is hand hygiene, safe food and water, and sanitation. For B, C, and D, the bloodborne ones, it is standard precautions, no sharing of needles or razors, and safe sex. There is a vaccine for hepatitis A and for hepatitis B, and the B vaccine also protects against D, since D can only infect someone who already has B. Whatever the type, the acutely inflamed liver gets rest, good nutrition, and strict avoidance of alcohol and hepatotoxic drugs while it recovers. Pause and select all that apply. Which hepatitis viruses are transmitted through blood and body fluids, rather than the fecal-oral route? Hepatitis A, Hepatitis B, Hepatitis C, Hepatitis D, and Hepatitis E. Hepatitis B, C, and D are the blood and body fluid viruses. A and E are the fecal-oral ones, food and water. The memory hook that keeps it straight, the vowels, A and E, hit the bowel, fecal-oral. The consonants, B, C, and D, are in the blood. And it is the bloodborne ones, B and C, that turn chronic and scar the liver. Chapter 9. Pancreas, Gallbladder, and Support. The pancreas makes powerful digestive enzymes, and in pancreatitis, those enzymes activate too early and begin to digest the pancreas itself. The pain is severe, in the upper middle abdomen, boring straight through to the back, and here is the classic tell: it is often relieved by leaning forward and worse lying flat. The top causes are gallstones and alcohol. The care is to rest the pancreas completely. Nothing by mouth so it stops secreting enzymes, IV fluids, and pain control. And 2 labs to watch, because a severely inflamed pancreas can drop the calcium and disturb the glucose. Right next door, the gallbladder, which stores the bile the liver makes and squirts it out to digest fat. When a gallstone blocks its outlet, it inflames, cholecystitis. The pain is in the upper right abdomen, often after a fatty meal, and it can radiate to the right shoulder. The tell is a positive Murphy's sign. The patient catches their breath in pain when you press under the right ribs and ask them to inhale. And if a stone blocks the common bile duct, the bile backs up, and the patient turns jaundiced with pale stools and dark urine, because the bile that colors the stool cannot get out. And 2 support skills that run across all of these patients. Nutrition, when the gut cannot be used normally, whether it is a nasogastric tube for feeding or suction, or intravenous nutrition. And the one rule to lock in, you verify nasogastric tube placement per policy, with an X-ray or a pH check. You do not confirm it by pushing air and listening, that method is unreliable. And the ostomy, a surgical opening of the bowel onto the abdomen. A healthy stoma is pink or red and moist. The finding you report immediately is a stoma that turns dusky, purple, or black, because that is the blood supply failing. Our patient's pancreas and gallbladder are intact. His story was the liver, the whole time. But notice how his one failing organ reached into the bleeding chapter, the fluid chapter, and the brain. And how each finding sorted cleanly into one of our 4 buckets. That is the point. So let's put it all together. Chapter 10, Put it together. Every GI decision fits the same 6 questions the next generation NCLEX is built on. What is happening? Recognize the cues. Why? Is it blocked, inflamed, bleeding, or failing to process? Which finding matters most? And in GI it is often the rigid abdomen, the bleeding, or the changing level of consciousness of a failing liver. What could I do? What do I do first? And did it work? Sort into the 4 buckets and every finding has a home. So, back to the silent abdomen from the very beginning. That patient, 3 days after abdominal surgery, with the distended, quiet belly, no stool, no gas, and vomiting. You had no framework for it then. Take a moment now and name what is happening and the first actions. Walk it. What is happening? A distended abdomen with absent bowel sounds and no passage of stool or gas after surgery. Why? The gut has stopped moving, a paralytic ileus. Extremely common after abdominal surgery. Which bucket? Obstruction, the functional kind. What first? Keep the patient nothing by mouth so nothing new enters the stalled tube. Anticipate a nasogastric tube to decompress it. Give IV fluids, and encourage early mobility because walking is what wakes the gut back up. The silent belly was never nothing, it was the whole diagnosis. If you keep 5 things from this course, keep these. 1. The GI tract is one tube, and every disease blocks it, inflames it, bleeds into it, or fails to process what is in it. 2. Black tarry melena is an upper bleed, bright red per rectum is lower. 3. A rigid board-like abdomen with rebound tenderness is peritonitis, a surgical emergency, and sudden relief of appendicitis pain means rupture. 4. The cirrhosis cascade is one story, portal hypertension into varices, ascites, and encephalopathy. And lactulose is titrated to 2 or 3 stools a day, never held for stooling. 5. A dusky stoma and an NG tube confirmed by air instead of by policy are 2 classic wrong answers. One last one. A cirrhosis patient becomes increasingly confused and drowsy with a flapping tremor of the hands. The ammonia level is elevated. Which finding and which intervention go together here? The confusion, drowsiness, and the flapping tremor, asterixis, with the elevated ammonia, are hepatic encephalopathy, the failing liver no longer clearing ammonia. The intervention that goes with it is lactulose, to trap and remove that ammonia through the stool, titrated to 2 or 3 soft stools a day. Recognize the cascade, treat the ammonia, and watch the mind come back. Same failing organ. A nurse who sees the whole story. That is the GI system. Not a jumble of organs, but one tube, 4 kinds of trouble, and a liver that ties them together. There are over 1,000 free study guides at clinicaljudgern.com. No paywall, no catch. If this helped, like it, share it with someone in your cohort, and tell me which system to build next. Educational content only, not medical advice. Go be the nurse who listens for the sound that isn't there.